Hi students, today we are going to see about articulators and interocclusal records in fixed partial dentures, and I am Dr. Jagdish from the Department of Prosthodontics. An articulator may be defined as a mechanical device that represents the TMJ and the jaw members to which the cast, that is the maxillary and the mandibular cast, may be attached to simulate jaw movement. Remember this simulate jaw movement because no articulator till now can replicate jaw movement. Replication means exact reproduction of the jaw movements, whereas simulation means trying to come close to the jaw movements. And till date, there are no articulators which can exactly replicate the jaw movements. The articulator is basically the representation of the upper and the lower jaws. And this articulator, which is shown here, is the most commonly or the beginner level articulator which is used by the students. So what are the uses of an articulator? The articulator serves as the patient in the absence of the patient, which means that we don't have to retain the patient in our dental office or the laboratory, and we can use it for holding the cast in a fixed relationship, for diagnosis and treatment planning, for better visualization of the bite or the occlusion of the patient. It can also simulate, as I told you before, it can only simulate and not replicate the movements. Briefly, the movements are the opening, closing, right and the left lateral relations. It also helps in fabrication of various processes like such as the removable dentures, fixed dentures, etc., including the most common processes like your complete dentures or even the advanced options like your implants. For everything, we definitely require an articulator. And when we go for a complete change of occlusion, we want to modify the existing occlusion, like increase or change the vertical dimension or decrease the vertical dimension or change the biting pattern, which is called as the occlusal scheme of the patient. We use the articulator. One of the earliest articulators which was used in dentistry before the invention of the modern day articulators was this barn door hinge articulator. The term barn refers to a small house or a shelter or a building which was used to store either food grains or animals. So this is the picture of a barn which is shown here. The door of the barn was a huge door which a hinge. So basically the hinge of the door was used as an articulator. So this was not a specialized instrument which was fabricated. Rather, they took the hinge and modified it for just a simple movement of opening and closing. The next type of articulator was a modification of these barn door hinge articulators. They were just called hinge articulators or the dog bite articulator. Basically, all these articulators had only one type of movement and hence they were called non-adjustable. They could just open and close, but they were not able to perform other movements or they cannot be adjusted to simulate the patient's exact jaw movements. Let us see the mean value articulator, which we commonly use in our dental curriculum at the undergraduate level. There are the upper member and the lower member. The upper member represents the maxilla, lower member represents the mandible. Then we have a vertical stop. This is called as the incisal rod. And we have an incisal pointer to position the upper or the lower incisors. Then we have the mounting plates to which the cast, that is a maxillary and mandibular cast, can be attached. And in the posterior, we have the condylar assembly, which actually represents the temporomandibular joint. So the common mean value articulator which we are using currently is based on the Bonville's triangle or the Bonville's theory, which says that when we connect or when we measure the distance between the two condyles and from the condyle to the tip of the mandibular incisor, the distance actually is around 4 inches, which forms an equilateral triangle. So this articulator is called mean value because the values or the measurements of the articulators are averaged and cannot be adjusted. Another type of mean value articulator is the articulator which is based on the Monson's spherical theory. So we all know the spherical theory of occlusion. We have read it in our theories of occlusion chapter. So this theory says that the mandibular teeth are arranged along a sphere with 8 inches diameter, which has a center around the glabella. So Dr. Monson, he fabricated this articulator called as the maxillomandibular instrument, which follows this principle of or theory of occlusion. The Hall's articulator is based on the Hall's conical theory. So this theory says that the mandibular teeth are arranged along a cone with an angle of 45 degree, and the tip of the cone lies at the external occipital protrusions. So just as we see these two types of articulators, that is the non-adjustable articulator or the mean value articulator, which is also called as the average articulators. Both these articulators are not very much sophisticated. Basically, the non-adjustable articulators can open and close, but they cannot move in lateral directions. Whereas the mean value articulators can open and close, and they also permit some lateral movements, but these lateral movements are also averaged and cannot be adjusted. These lateral movements are basically depending on one of these theories, that is the Bonville's theory or the spherical theory or the conical theory of occlusion. So again, just to emphasize on the parts of the mean value articulator, the upper member, which has the condylar analog, which represents the condyle, and a shaft which connects the condylar analogs. Then we have the incisal pin, incisal pointer, and the incisal table. The lower member comprises of the condylar tract, which is actually representing the path taken by the condyle, and the incisal table. So here we have the condylar tract shown in detail. The condylar tract actually represents the horizontal condylar guidance or the inclination of the horizontal condylar guidance, which is actually the angle between the path of the condyle with the horizontal plane. But here we see that this angle is fixed and cannot be modified in this articulator. So more sophisticated articulators, which are called as semi-adjustable articulators, are more commonly used for fixed partial dentures because of their improved accuracy and the ability to modify or to adjust or program the articulator according to the patient's jaw movements. So these articulators, the more common ones are the Hanau H2 and the Hanau wide view, and they are much more adjustable compared to the non-adjustable or the average point articulators. This means that these articulators have a programmable or a modifiable horizontal condylar guidance. The lateral condylar guidance can be modified, and at the same time the incisal table can be modified, and in some articulators even the intercondylar distance can be modified. So these are some examples of the semi-adjustable, which is dentators, and the whip mix. The whip mix provides 3 intercondylar distance, the small, medium, and large, which is adjustable on the articulator. The more recent articulators are the Artex and the Stratos 300. These are much more sophisticated articulators which are semi-adjustable. Next we have the fully adjustable articulator, which have much more functionality, and they also accept a Facebook called as a pantograph for better pantographic tracing or location of the hinge axis. So the most commonly used fully adjustable articulator is the DINA D5A, though it is not very much used for all cases. When the clinician wants a very accurate bite, especially in case of full mouth rehabilitations, these are used. So basically we can classify the articulators based on the adjustability, that is non-adjustable, semi-adjustable, and fully adjustable, based on the theories of occlusion, Bonville's, Monson's, and Hall's theory. And the most sophisticated or the accepted classification is the University of Michigan classification in 1972. So the class 1 are the simple hinge articulators. Class 2 permit hinge plus lateral movement, but they do not accept a face bow or they do not permit bite records, which means we cannot take any bite record of the patient and use it on the articulator. In class 3, they are hinge articulators which have lateral movements, but the difference comes here where they accept face bow and they also accept some interocclusal records. Basically, they are semi-adjustable articulators. And class 4 is the hinge type articulator, which much more complex movements which accept face bow, especially this face bow is a pantograph and not a regular face bow. And because of this, we are able to program the articulators much better and they are called fully adjustable. So this is a brief classification for your reference. To sum it up, class 1 and class 2 articulators are not very commonly used for fabricating fixed partial dentures, or class 3 and class 4 are much commonly used for their accuracy. If you want to fabricate full arch reconstructions, or we are talking about modifying the patient's occlusion, then we have to definitely go for class 3 and class 4. Class 1 is definitely not at all used in FPDs, but class 2 can be used in selected cases like your single crowns or a very small processes where we are not modifying the patient's existing occlusal scheme. So now let's come to the second component of the articulator, which is the face bow. A semi-adjustable or a fully adjustable articulator is always used along with a face bow for the complete functionality of the instrument. So what is a face bow? A face bow is a caliper-like instrument which is used in dentistry to record the relationship of the maxillary and maxilla to the TMJ. So we have dealt with this in detail in the complete denture chapter already on articulators and face bow. And just to brief you, there are two types of face bows. The first one is called the arbitrary face bow, and the second one is called the kinematic face bow, which gives you a true hinge axis. The arbitrary face bow can further be divided into earpiece face bow, or the face bow which records the hinge axis from inside the external auditory meatus, which means you can place this into the external auditory meatus of the patient. Whereas the fascia type face bow relies on positioning this face bow on the fascia, or it is placed exactly over the soft tissue over the condyle. The kinematic face bow is a much more true face bow, or in aspect it represents or it can record a true hinge axis. And it is most commonly used with a fully adjustable articulator.